So I put together this document and I did go through a lot of board review material. So I'm trying to focus on important stuff you guys need to know for boards. You guys, previous classes do really well on boards as far as pathology diagnosis based on oral path 2 stuff that you learn pretty well. And so I tried to focus on things that are maybe a little more rare that might come up on, at least they show up on board review materials. Some of the stuff's really rare. So I'll try to point out things where I think it's really important today that you know for a couple of weeks from now. And you guys do have a couple weeks to study after this. So I'd say focus on board review stuff. But yeah, let's get into the lecture. And yes, I themed the whole thing after Mr. Glass. I was referring to him so often, I figure I might as well just go all out. Even dug out my old purple shirt so I could match. So I'll respond to Mr. Glass today, if you want to call me that. So we'll go through one part and then we'll do a Kahoot on that. And then the second part and second Kahoot. So fractures and healing. We'll look at different types of fractures and then kind of the timing of healing, the different stages or phases. There are a couple of different ways they classify it. And talk about the other different forms of arthritis. Not all of them, but the major ones, I guess. These different systemic conditions, and then a few other bone lesions. And some of this, we've covered in oral path 2, so you might want to refer back to those lectures for more thorough understanding. A lot of resources. How often do you guys read your books? Pull out your vital source. So yeah, I referred to a lot of these different sources. Like I said, I tried to refer back to some of these board review courses, especially to see what they might ask on. But you do need to recognize type of fractures. So simple, just like it sounds, the most common, where you just see a crack in the bone. That's your simple fracture. Compound fracture, what's that? When it's piercing through the skin. And so if I ask you on the exam and I have a question, I'm going to explicitly say, oh, punctures through the skin here, like you'll see in the next slide. If you don't see that, then don't assume it's a compound fracture. Comminuted is when the bone is crushed into 2 or more pieces. Displaced, like it sounds, the bone fragments are out of place, so that's when it needs to be repositioned into place or is not going to heal correctly. And we'll talk about risk factors of non-healing. Stress fracture is slowly developing fracture, a small fracture from increased physical activity where the bone's subjected to repetitive loads. So that's like for you runners, right? I know a couple of you runners. You get shin splints, that can eventually lead to stress fractures. And so different things that can cause that. This is an example of a green stick fracture. And so I included a picture right here. Let's see, you see where I'm pointing? This is how it gets its name. If you imagine breaking a stick that's still somewhat live, you get the bark remaining in place. And so what type of patients do green stick fractures happen in? Kids, yeah, probably no one in this room. And so that's where you get, it's somewhat more malleable than typical bone or than the aged bone, mature bone. And so it looks like a green stick. How could you tell this was a kid just looking at it? And look at the bones, look at the epiphyseal plate, the growth plate. That's not a fracture right there. That's just an open growth plate. And you guys just learned about bone histology and development, right? The carpals aren't even completely developed. So this is a young kid. That's who gets the green stick fractures. Then what do we mean by pathological fracture? Probably mentioned that in oral path 2. Osteoporosis, that could be. Yeah, osteoporosis is more susceptible to fracture. That's a type of pathology. But any specific lesion, you could have OKC, a big ameloblastoma, and then if that fractures, and that's typically what I think of with pathological fracture, some big lesion. We'll talk about systemic diseases, hyperparathyroidism, they lose bone mineralization in any of these systemic diseases that we're going to talk about today, but they also get brown tumors. And so those could cause a pathological fracture. Let's see, I'm going to try to go somewhat fast through this lecture, and then we'll have more discussion during the Kahoots. All right, so could you recognize each of these? What's this one on the left? That's your green stick. What would this one be? If you just look at this, this is a, what do we call it? Simple fracture, but of both bones in the forearm. But the fact that it points to broken skin, I'm indicating compound fracture. And then this one here, Remember the name for that? Comminuted. Multiple pieces. That's a tough one. So different sources either talk about the stages or the phases of healing. And so I've tried to kind of lump those together so you can see what they're talking about. If we talk about 3 phases, because even different board review material, it'll either talk about stages or phases. So generally you have 3 phases: inflammatory, which is within the first couple of weeks. The first day or so is when you get the hematoma formation. And another part of that reactive inflammatory is forming granulation tissue. And so that's within first day to 2 weeks. The reparative phase, just think of maybe weeks to months. Maybe the first month or 2. Really lamellar bone formation, that could go several months. So that's your reparative phase. And then for the final histological stage, that correlates with the last phase. And that can go on for months to years. We're thinking 3 to 4 months out to, in older people, it may take years and you still see signs of that fracture. In a younger person, they heal a lot faster. They have a lot faster bone turnover, and that happens a lot more rapidly. And so when I talk about timing, we're going to talk about averages. So think, maybe you're a middle-aged person, fairly healthy, but middle-aged person. And remember that for timing. So hematoma, we said that's immediate, the hours, maybe within the first day. Blood clot forms, and that starts to form a fibrin mesh seal. So there's a seal around it, so things stop leaking out of there. We'll talk about one of the sequelae of a fracture is you get fat embolisms, and that can be very problematic. But yeah, that's the first thing that happens. You want to develop a seal around it, and that's what the hematoma does. And then also part of the inflammatory stage is a granuloma formation. So within the first couple of weeks, you get different inflammatory cells that migrate to it. They release these cytokines that stimulates the osteoclastic and osteoblastic activity. And that they'll refer to sometimes as the soft callus. Typically when I say callus, I'm talking about the hard callus. That's going to be the next stage. So soft callus may refer to the granuloma stage within the first couple weeks. So this is what I typically call the callus. And what I think most texts and most literature refers to as the callus stage is when it's a hard callus, when it starts calcifying. So this is when radiographically you first start to see signs of calcification around it. You're getting woven bone, which is later calcified. And so yeah, within the first 2 to 3 weeks, but within a month, you should start seeing calcification. Again, we said this is average. If you have a 60-plus-year-old patient, it may take longer than that. With a really young patient, it may be quicker than that. But just remember the averages, because I may ask you about timing. Lamellar bone stage, so that, really think of the order of months. So beyond 3 weeks, once you've really got that hard callus stage and it's starting to form the lamellar bone around it and within it, so that cartilage in there really starts to undergo the endochondral ossification and starting to form the trabeculation again. And so that can last months. And then we didn't show the last stage here, the remodeling stage is really just, even when it's mostly healed and the bone is strong, maybe even stronger than before, you can still see signs of the fracture. You see these bulges around it, right? And it's still in the laminar stage. And so that remodeling stage is just remodeling back to the normal contours. But at this point, in the laminar stage, it's pretty stable. Actually, at this point, this is when you've reached your first stage of stability. Maybe you don't want to go back into contact sports if it's just a hard callus stage. If it's a significant fracture, it's going to take months before you want to go back and put force back on that bone. And so I just like these images. So took from Radiopedia, which is something I refer to a lot as a radiologist. Right, you've got your normal bone here, your periosteum, your marrow space or medullary cavity, your cortical bone. We have vasculature going through the bone. You get a fracture, and so what's the first thing that happens after a fracture? Hematoma formation. How long does that take? Hours, yeah. So immediately you have blood starting, just like with any injury. Almost immediately, blood starts accumulating. You get platelets, you get different blood cells that start forming this hematoma, and they seal it with this fibrin mesh seal. And then what's after hematoma? Granulation. This is still part of the inflammatory phase, but the granulation stage. So granulation tissue starts to accumulate. And that's what forms that mesh seal around it. And you have osteoclastic and osteoblastic activity. First of all, osteoclasts start to resorb some of the loose fragments. You start to get revascularization in this stage. And I said I'd refer to that. Some people refer to that as a soft callus stage. You get when you have that mesh seal around it. But at this point, you're still not seeing calcification radiographically. It's still not stable. And then this kind of jumped ahead here, but oh no, this is showing the hard callus stage. And so this is when radiographically, it's not going to look like normal bone yet, but you just start to see almost a granular calcified matrix around it. And that's when you have that first initial stability, still probably not as strong as you would want. And then the remodeling, which we said, I think on the orders of months. I think we said 3 weeks to several months for remodeling. And at this point, it is the hard callus stage. So it is relatively stable. And then here's all that in one slide. So remember inflammatory reparative remodeling. Also remember hematoma granulation. What was the reparative? You got the hard callus stage, and then the lamellar stage, which it doesn't really show here, and then the remodeling stage. And so how old is this patient on the top row there? Well, yeah, just a baby. Here we said usually the hard callus stage is how long? We said, a month. Well, we said 6 weeks, I think. Hard callus. Oh no, it was within weeks, sorry. But within about 3 weeks is your average for hard callus stage. But in this baby, 7 days later, they're already the hard callus stage. So these are just averages, but do remember the averages, because if I ask you a question, I'm going to be asking about averages. So this is a lot faster than your average. Within 2 weeks, this is almost in that lamellar stage. Maybe it is heading toward that lamellar stage. So this is very sped up compared to an older patient with a fracture. Same one with this. So this one was a humerus fracture. Here's a femur fracture. 3 weeks later, definitely not even 3 weeks later, but it looks like it's well into the hard callus stage. It's starting to get into the lamellar stage. And just 2 months later, it almost looks completely healed. 3 months, yeah, completely healed. You couldn't even tell that there's a fracture here. Even 2 months, it's hard to tell that there's some changes to that bone. So very accelerated in babies and young patients. And then this is more average. 6 weeks later, we said hard callus stage was about 3 weeks later. This is probably beyond hard callus stage. You're seeing more than just kind of granular calcifications around it. This is into the lamellar stage. So this is about average, this fibula fracture. And then an older patient, 60 plus, maybe this patient's in their 70s, even 80s. So, they had to put a post in here just to stabilize it. Here it takes 6 weeks and it's just getting to the hard callus stage. So it's delayed in this older patient. 6 months later, it still looks like it's just in the lamellar stage. So just kind of showing the difference in timing. Here's everything summed up into one slide. Right, everything we talked about, the phases here, reactive, inflammatory, reparative, remodeling. Those first 2 phases are kind of broken up into 2 histological stages. Hematoma formation in the first day, granulation tissue in the first couple weeks, callus or hard callus formation. Remember, sometimes people refer to this as soft callus. This is where you first start to see calcifications within a few weeks. And then lamellar bone formation, usually on the order of months, and then it may be several months to years for it to totally remodel. So this will kind of help you when you're thinking about implant placement and bone healing from implant placement. If it's an older patient, it's going to take longer for that bone to really heal. And if you place bone graft, think of the same kind of timing. It takes several weeks for that bone graft, at least several weeks for that graft to really solidify in there and calcify. And it can be delayed if a patient is more unhealthy. And so do understand the reasons that there's non-healing of bone fractures. This shows an example of a non-healed fracture. A big one is interposition of soft tissue, especially it happens when there's excessively displaced fractures, comminuted fractures. If there's mobility, this is why we stabilize fractures, right? It supports healing. If it's stabilized, then everything we just talked about is going to work a lot better. Can lead to a false joint, or they call it pseudoarthrosis. Infection, obviously, that's more common with compound fractures, if there's a source of infection reaching it. Another one is ischemia. And so if someone fractures their jaw, which one is more likely to not heal because of poor vascularization, your maxillary or mandible? Yeah, the mandible. So it can happen. And I briefly mentioned this earlier. This is a common sequela of bone fracture. In fact, whenever there's a fracture, there's going to be some embolism of fat from that marrow space in the bone. And so that does get into the circulation. If that's significant enough that it alters plasma lipids, then they could end up with some symptoms from a fat embolism. But only about 10% do show symptoms. This fat embolism can go into the lungs, so it can lead to pulmonary insufficiency, neurological symptoms, anemia, a lot of different symptoms that they can have. And so know the timing of this. It's within the first few days, because it's really only within that first day that these things are getting released. And so usually within those first few days, they get a sudden onset of either altered heartbeat, have a tough time breathing, they're irritable, restless. Sometimes it can lead to delirium, and in severe cases, even coma. So it is a potentially very severe sequela of a bone fracture. All right, I'm going to talk to you about osteoarthritis, so I'll go through some of this pretty quickly, just point out the really important points. Know that your typical osteoarthritis, who does that occur in? What type of patients? Older patients. Can be men or women. Maybe it's a little more common in women, but we see this all the time. If I'm looking at a CBCT of a 70-plus-year-old, I expect to see some changes of osteoarthritis, either in the spine or the TMJs or both. And so very, very common disease, as you know. It's considered non-inflammatory, even though some studies, and one study I did with some guys at Boston University showed really low-grade inflammatory markers in there. So I think of all the signs that you see radiographically from arthritis, very similar to as if it is inflammation in the bone, but it's a very, very low-grade inflammation. And so, technically it's considered non-inflammatory. Then that contrasts it with these other forms of arthritis we're going to talk about. Rheumatoid is more considered inflammatory, so this is considered non-inflammatory. It is a degeneration of the articular cartilage, and really kind of an unknown reason. And we'll talk about the different signs that you can see. Here they are. You get flattening of the joint. The bone kind of remodels first, and then reduced joint space, especially in a joint like the TMJ, where you have that fibrocartilage disc that should be between the two osseous components. That disc, and a lot of people theorize that that disc has to degenerate before you get signs of osteoarthritis. And so if you see signs of arthritis, it means that the disc is either out of place or it's completely degenerated, which can happen, or partially degenerated at least. Erosion is just a kind of a concavity along the bone surface. These both look like erosions. The subchondral cyst, really that should be, so I think I draw this cartoon a little bit different, where that should be sealed over with intact bone. What it is a just progression of an erosion lesion. Whenever you have inflammation, and I said this is non-inflammatory, but all these changes are just like low-grade inflammation. Whenever you have inflammation, it goes through bouts of active or inactive, where it really erodes the bone, right? Remember, with acute inflammation, you have erosions, you have radiolucency. With chronic inflammation, it's more sclerotic, and it lays down more bone. And so it goes through intermittent bouts of erosion and sclerosis, and that's how you can get these subchondral cysts. The sclerosis sometimes is referred to as eburnation, kind of like hardening. So the cortical bone becomes very hardened. What's that going to look like radiographically? Here's just a cartoon. But if that bone becomes hardened, it's more opaque. And so you might describe it as thickening of the cortex. Last one here is an important one, osteophyte formation, which I've shown you examples of, and we'll see more examples of. So this one just shows really subtle signs. In fact, it may be questionable whether this is truly osteoarthritis or you want to just classify it as physiological remodeling, where you just get a little bit of flattening. Here we have the articular eminence flattened as well. This is the condyle. We do get here, though, a little bit of cortical thickening, so a little bit of sclerosis, but very minor changes. This one's a little more significant. You can see sclerosis, and what would I call this? Bird beaking, and what is that of those 5 signs we just talked about? Osteophyte formation. And then here we see it in a cadaver segment. This one's pretty significant, actually. You see sclerosis, you see subchondral cysts. Looks like more of a soft tissue thing in here, but it's not normal bone. Normal bone is going to look more like normal marrow space in here. But both of these are flattened and sclerotic. There's our big subchondral cyst, sometimes called Eli cysts. That's pretty much the major sign here. Maybe you'd classify this as a osteophyte. This one shows flattening. It also shows loss of the cortex. So it looks like erosion. It's not necessarily scooped out, but if you look in the sagittal plane here, it's more of a scooped out and definitely an erosion lesion. And so a lot of people think that the more active form of osteoarthritis is when it's eroding. And so when you see these erosion lesions, it may correlate more with symptoms, with active symptoms. If it's more like this and it's sclerotic, or if it's sealed over, it might be more in that regressive stage where it's not active and might not correlate with symptoms. Although here in this case, see how little joint space there is? That disc is probably out of place. They could very well have symptoms. And so these things you've always got to correlate clinically with what symptoms are going on. How would you guys describe these ones? Is there sclerosis? I would say, yeah, there's sclerosis going all the way through here. In a nice healthy one, you just have one smooth, kind of uniform corticated border. I would even say it looks a little bit ragged, and I describe that as small erosions on that superior border. And then an osteophyte formation. This one is more sclerotic, also very flattened, reduced joint space. You can tell, even though I don't see the disc in a CBCT, you can tell that there's not a healthy disc in here. Probably completely out of place, probably deranged. Osteophyte formation. What do we call these ones? Yeah, subchondral cysts. Reduced joint space, again. I probably should have given you more healthy examples for comparison. All right. Remember joint mice? What's a joint mouse? You like my dancing mice? So what is a joint mouse? What causes it? Fractured osteophyte. So we'll talk about some other things that cause calcification within joint space. And how can you tell it's, or what would lead you to think it's more likely joint mouse rather than one of these other things we're going to talk about? Opacity, you talking about the sclerosis or the opacity of the mice? Maybe, if they're very sclerotic. But I want you to look for signs of the joint here too. All these signs I just told you, because joint mice come from osteophytes, which means they had osteoarthritis. So if you see other signs, significant signs of osteoarthritis in the joint, it's very likely to be a joint mouse or joint mice. And usually, maybe there's one or two. Remember synovial chondromatosis, and it's all over the joint space? Usually with joint mice, it's not really all around the joint. It's just here where you can imagine osteophytes having fractured off. So a couple little hints there. And then what about differentiating this from osteochondromatosis, or no, pseudogout, which is synovial chondromatosis. Remember pseudogout, chondrocalcinosis? Chondrocalcinosis it's like a form of gout. And so think of little particulates of calcifications. It almost looks like a ground glass calcification within the joint space, and we'll show you that. Oh, here's an example of a more normal one. Very subtle signs of maybe flattening, debatable osteophyte formation. But yeah, this looks almost normal. Little minor amount of flattening like this, it could just be anatomical variation, physiological remodeling. And so this one's almost normal, I would say, versus this one. Here we get our kind of bird appearance. Looks like an eye and a beak here. So we got our subchondral cyst, our beaking osteophyte formation. These are fairly moderate degenerative changes. Reduced joint space here. In this one, we see a nice erosion in the superior border. And I always like to look in the sagittal as well as these are sagittal. This is more the coronal view. I think I said that wrong. It's an oblique coronal view. But you get more of the coronal view, and you see this big subchondral cyst. You see the erosions, sclerosis around it. Even in the glenoid fossa here, you get some erosions. So it seems like first you see the changes in the condyle itself, and it's more rare to see changes in the either the glenoid fossa or the articular eminence, although you can see those. All right, this is a 12-year-old patient. What do you think? Think of what you just learned about bone growth, bone development. The condyle is a growth center, and the cortices of the condyle aren't going to be established until around puberty or after puberty. And so in a 12-year-old, you don't expect to see that nice, well-defined cortex like we did in an older patient like this. This is what you're looking for normal. Pretty much intact cortical borders. But in this case, it looks kind of granular. This is just a developing condyle. It does kind of give the appearance of beaking, but with the age of this patient, I would just chalk this all up to normal development. Unless you get significant loss of height, loss of volume of the condyle, which can happen in juvenile arthritis, which I've talked to you about before. But yeah, if they're not symptomatic and you don't see these changes, loss of the height of the condyle, both these look nice and healthy, really. So that's just normal growth. And then just to show you that you see the same changes in the spine, what are we seeing in the spine? This is a joint space right here. This is the odontoid process or the dens of C2 and the anterior arch of C1. There should be a gap there. So just like with the TMJ, I'm showing you loss of joint space, there's osteophyte formation. And then these are the intervertebral discs. This one looks a little more healthy. Maybe there's a little bit of excess growth here, but these show osteophyte formations. And to some degree, you get calcification or ossification of the anterior longitudinal ligament, which extends anterior to the vertebral bodies. That can also cause problems with breathing, swallowing. It's not quite to that degree here, but just to show you the degenerative changes you can see in any joint. So in the head and neck, which we worry about, you've got to look for these in the spine. Obviously, you're looking for any type of pathology in the spine, but this is the common one, just osteoarthritis. There's even calcification within the disc space here. So there's disc degeneration, there's calcification. Patient's probably going to have neck stiffness and some pain, your typical osteoarthritis. This one in the sagittal view, not quite as severe as that last one. We do get some osteophyte formation, but these very black areas, that's something we didn't see in the TMJ. They look like subchondral cysts, but in the spine, particularly in the spine, the vertebral bodies, they can get filled with air, and they'll call those pneumatocysts. It's still just a kind of a variation of an Eli cyst is how I see it. It's kind of a different, there's varying opinions on what causes that. But for whatever reason, air comes into these small cysts in the spine, but it is still just related to osteoarthritis. Here's a case where this is a facet joint. So I was showing you more the mid-sagittal plane. That's where you look at the intervertebral joints. Of course, laterally and posterior, you have the facet joints in the spine. This was a case where there's fusion. What looks like the right C2, C3 facet joint. And so you'll see degenerative changes there as well. This may be just actually a congenital fusion. You get a lot of variations of the spine and their development. Probably not that significant if that's all it is, although it can lead to a little bit of reduction of spine mobility. So just some interesting cases there. I may ask you to recognize degenerative disease, probably in the TMJ, and differentiate from some of these other things that I talked about, synovial chondromatosis or chondrocalcinosis. Do you recognize the difference between osteoarthritis and rheumatoid arthritis? We just said osteoarthritis was non-inflammatory, and the big difference here is this is considered inflammatory. So they do get this granulation tissue inside the joint space. They refer to that as a pannus. So this is the one with a pannus. This one is also more common in elderly patients, but tends to, or it can occur younger. So if you have osteoarthritis starting to occur in the 30s or even earlier, it's that more goes along with rheumatoid arthritis, although we do see osteoarthritis sometimes onset pretty early. I was getting arthritic changes in my joints in my 30s, although I have a different disease that I'll talk to you about later that probably contributed to that. So rheumatoid, it tends to first affect the peripheral joints, if you remember, the fingers specifically, so more peripheral joints. But in more than half patients, or about half the patients, it'll affect the TMJs. A lot more common in females, but not exclusive to females. This is known to be very erosive, but then at the same time, it talks about it can cause bony ankylosis. So I just think of this and all these other forms of arthritis as being a severe form of osteoarthritis. All the other signs can look similar. The book sometimes talks about rheumatoid as being more erosive. In fact, I'll show you a radiograph of someone's hands, and it just looks very radiolucent, kind of osteopenic, especially around the joint spaces. But to some degree, they can get ankylosis. Usually that's because of loss of joint space, and then they get the fibrous ankylosis. We'll show you examples of all that. This is the hand one. The big one here is, actually it's the ulnar tilting or ulnar drift of the fingers. That's kind of a key feature of rheumatoid arthritis that you don't get in osteoarthritis. Everything else may look similar. There is more osteopenia. I'm probably not going to show you a hand radiograph, but just to point these out, more osteopenia right against the joint spaces. And then from this lateral ceph, really the only thing that stands out is the anterior open bite, which has occurred from loss of the condylar head volume. And so as that condylar head erodes, the posterior part of the mandible will shift up as they're trying to bite down, and then it fulcrums on the posterior teeth, on the molars, and the anterior bite opens. And that can happen in any really severe arthritis, anything that really severely affects the volume of the joints. So if you saw this in a really young patient and they're starting to develop this anterior open bite, it could be juvenile arthritis. In the case of a teenage girl, it might be that cheerleader syndrome we talked about. I'm not going to talk about every one of those types of arthritis again, but this is a good one for rheumatoid. And one of the things that comes up in board review material about rheumatoid arthritis is the way that joint erodes. It almost looks like a sharpened pencil of the condyle. So it erodes from that top and anterior joint surface, and it leaves this sharpened pencil appearance. You don't really see that here. Maybe I had another example that showed it. So yeah, gross erosion. This was an interesting point. It's not really known to cause osteophyte formation, but you'll see it. And they assume that can be related to it causing a secondary degenerative joint disease. So it can be kind of combined. We talked about fibrous ankylosis. Let's see, I don't think I go really that much into symptoms, but if I were to compare symptoms with osteoarthritis, a big thing would be time of onset. Even with osteoarthritis, you can be stiff and sore in the morning, but that tends to go away. With rheumatoid arthritis, it tends to be more severe. With any of these autoimmune inflammatory arthritis, they tend to be more severe in the morning. In fact, I'll talk about what I have, which is, I think of as a similar form. It's autoimmune type of arthritis. It's not rheumatoid. But I would wake up in the middle of the night because my back hurt so much I couldn't sleep. And so I'll talk about that. And so rheumatoid, it would be similar to that. It's one of these autoimmune things, worse in the morning, actually gets better throughout the day. Osteoarthritis, they may be stiff and sore in the morning, but it actually gets worse throughout the day with use. That's your typical osteoarthritis. And so that's a big thing that differentiates these two. I don't know, I think if I were to guess, it's because you kind of work out the inflammation throughout the day. Like it's an accumulation of inflammation. In fact, one of the ways you can test from one of these autoimmune inflammatory arthritis is patients have inflammation in their system. That's one way I was diagnosed. I had just inflammation in my blood that they were able to test for. And I think the same is true. Yeah, it says right here. The same is true for rheumatoid. It's inflammatory. They have elevated sedimentation rate, CRP. These are markers of inflammation. And of course, they have rheumatoid factor. That's where it gets its name, rheumatoid arthritis. And so that one they can test for. Any other questions? But yeah, in osteoarthritis, they're not going to have these. And that's why it's considered non-inflammatory for osteoarthritis. So again, it just looks like a really severe arthritis. Once you're starting to get where it looks like puzzle pieces matching from one joint surface to the other, in this case, the condyle and the glenoid fossa, it's very likely that they're going to start having fibrous ankylosis. And so that's what fibrous ankylosis looks like. When you actually see that bone-on-bone contact, they may get actually bony ankylosis. So with fibrous ankylosis, their mobility is going to be pretty limited. You know, anywhere from, you know, just reduced to a few millimeters, or maybe they can only open a few millimeters. If it's true bony ankylosis, they're not going to be able to move at all. And so when it gets to that point, basically you're going to treat these based on symptoms. If someone can't move enough to open at all, that's when you're finally going to the point where you're thinking they're going to need resurgery, maybe even a joint replacement surgery, but you leave that until kind of the last option. So with typical arthritis, any of these, your first line of treatment is going to be, well, if you suspect a rheumatoid or inflammatory arthritis, you want to get that diagnosed. I could tell about the medication I'm on is an immune suppressant, which really helped me. I'll talk about that in a little bit. In the case of just osteoarthritis, though, probably just NSAIDs, rest, try not to overwork those joints. To some degree, diet, but yeah. All right, pseudogout versus gout. Let's see, I think gout specifically does come up a little bit on board review stuff. That's uric acid crystals deposit in the joints, really known to affect the first toe joint. This one's not as known. I think it can affect the TMJs, but this is not as well known to affect TMJs as much as pseudogout is. That's why I introduced you to pseudogout in oral path 2. They're really similar though in that you get crystal deposition into joint space. And it can be really painful, but it's just a different type of crystal. Right? Uric acid is gout, and then calcium pyrophosphate crystal deposition is your pseudogout. Sometimes this may correlate with diabetes, hyperparathyroidism, some of these other metabolic conditions that can lead to more calcification, and then they get pseudogout. Another form of this is you see calcifications. I showed you the image of the dens, the odontoid process in the spine. You get calcification around that, and that's a form of pseudogout. Yeah, where you might see it is in the TMJ. Let's see, they call these tophus. I guess the plural of that might be tophi, I'm not really sure. But you get a large calcification around the joint space. We said the most common place to affect was that first toe joint. And you get these little calcified tophi, I'm gonna call it. But you can also get erosions. Here's erosion of that, what do you call that, metacarpal? The distal end of that. And you also see some tophi around there. But I've seen images of osteoarthritis, rheumatoid arthritis. Looks similar, maybe not quite equivalent to this. These tophi are more round. And so that's kind of a common appearance with gout. Versus I don't know why. I don't know if anyone knows why they specifically accumulate where they do, but that's just kind of a common location of gout. Probably the most common place for it first to develop. And then pseudogout tends to do other joints. You can see it in this is a knee joint. But yeah, I don't know why they accumulate where they do. And then I've shown you these examples of it in the spine, or in the TMJ. Talked about how it can be in the spine. So you see how it looks like more, you can imagine this as being little small crystals calcifying, rather than little small pebbles like your joint mice, or in the case of, what's the other disease called? I guess I have it named right here. You see the difference here? Discrete, well-defined, round things. They almost look like little bones. Not so much joint mice, right? Because, I mean, I don't see all of the joint. It's hard to say if there's degenerative joint disease going on. But what I see here, it looks like a nice, well-defined cortex. And then I've told you joint mice, usually they just fracture off where you typically see the osteophytes, which is more in the anterior joint space. This is all around it. So that's synovial chondromatosis. And contrast that with pseudogout, which is more, if you can imagine, those crystal-like deposition. Does that make sense? So definitely be able to distinguish between these types of things. Now we'll go a little bit into synovial chondromatosis. This one is more of a tumor. It's a benign tumor that accumulates in the joint and causes those discrete pebble-like calcifications. So looking at this cropped panoramic image, why would I say that's synovial chondromatosis? They call it osteochondromatosis, but synovial chondromatosis opposed to those other ones. What's that? Which one has more of a ground glass? The other one, yeah, pseudogout or chondrocalcinosis should be more the ground glass. Do you see how this is more discrete pebbles? Maybe if you zoom in here. Why would you not say this is joint mice? It doesn't look like fractured off osteophytes. I don't see signs of osteoarthritis. This actually looks like a nice healthy joint, a nice healthy condyle. And it goes all the way around it. I think it's easier to see in 3D images, right? You can really see the discrete pebble-like calcifications. Any questions about anything so far? Ready to jump into Lyme disease? Something that seems like every board review book talks about is Lyme disease, which in your going over infectious type diseases, you probably talked about this already. Yeah. The agent is Borrelia burgdorferi. And then they distinguish into early, disseminated, or late symptoms. Early on, you get that bullseye rash, the erythema migrans, localized to the tick bite, right? It's an infection. It kind of spreads out from there for whatever reason. It causes this bullseye appearance. But it can also be associated with any type of infection, right? Fever, chills, malaise, fatigue, those things go along with infection. So definitely know the different symptoms of Lyme disease. And then after the first month, so that was all within the first month, early symptoms. After the first month, it can disseminate. It can start to affect nerves. So you get neuropathy, pain or paresthesia. Secondary skin lesions, you might get rashes in other locations. Can lead to heart problems. And then the arthritis you get from it is actually considered more of a late one. So after, months to years, and you might get swelling in a joint. I think of this as a form of infectious arthritis. It's like an infection that then settles into a joint, thinking and reasoning problems because it's affected neurons. So it can be a pretty serious disease if it occurs. Where does this occur in the country? Yeah, Northeast. I lived in Massachusetts, and we lived out on a farm that was away like 50 miles out of Boston. And we had ticks like crazy. Our dog would come in covered. So this was something we were at risk of. Fortunately, none of us, at least that I know, I've got Lyme disease. Maybe it affected my reasoning so much I don't realize that I had it. But yeah, it can be pretty severe. Here more in Utah, we're more concerned with Rocky Mountain spotted fever, right? Did someone get that? But yeah, this is the one that comes up on boards. So this is what I'm talking about. Other forms, which I'll just mention briefly. I've talked about juvenile idiopathic arthritis before the age of 16. Let's see, what I didn't mention here that I also mentioned was idiopathic condylar resorption. I think of any of these as just a severe form of arthritis. So if it's a young kid, probably more your juvenile. They used to call this juvenile rheumatoid arthritis, but this one is not necessarily affected, or they don't necessarily have the rheumatoid factor. So it's not really a rheumatoid one. So they changed it to juvenile idiopathic arthritis. The idiopathic condylar resorption was the cheerleader syndrome, where they can get very severe resorption of the condyles. And either of those, they can get that anterior open bite because you've started to lose that condylar height. Infectious arthritis, I said I consider Lyme disease as kind of a form of infectious arthritis because you have a bacterial organism causing it. Those will have signs of infection within and around the joint. And then this is, what I have is one of the forms of these seronegative spondyloarthropathies. These are associated with HLA-B27, so they can test for this marker. They also test for those inflammatory markers like they do with rheumatoid. And I guess I'll just kind of talk you through my story. I used to play a lot of basketball. I got to the point where I could only play a couple hours and my hips would start hurting. I mean, this sounds more like osteoarthritis, so this doesn't necessarily go through it. So the symptoms that really match it are more, how I told you, I would wake up at like 4 a.m. My back would just be killing me. I'd have to get up for a while and move around or rest it. Because with most of these inflammatory ones, like I said, you do better with movement and mobility, interestingly. But for me, it was also affecting my function. Like I got to the point where I couldn't hike more than a couple miles and then a mile. Like something's seriously wrong. And they kept diagnosing inflammation in my sacroiliac joint, which is a typical one for ankylosing spondylitis. And it typically does occur in males around the age of 30. And they do have this marker. And so finally I got an MRI and got that inflammation they saw the inflammation and that was on their differential. And so I was diagnosed and started taking an immunosuppressant, take Humira, which unfortunately, it does have side effects and I'm worried about infection. But I think if anything, my immune system is overactive. So it's kind of more just countered it and brought it down to normal. But it really kind of changed my life because now I can do things I was thinking I'd never be able to do. And I started running. And so, yeah, good to get these things diagnosed. I guess the takeaway from that, the comparison from inflammatory arthritis to osteoarthritis, and when it typically tends to occur, which is inflammatory in the morning, osteoarthritis more at night. What would this one be here? What's this arrow pointing at? You got a little periosteal reaction. We see an erosion, that could just be osteoarthritis or any type of arthritis. But osteoarthritis doesn't cause periosteal reactions. What does? What did I say to think of with a laminar periosteal reaction? The first thing you should think of is infection, osteomyelitis. But in this case, probably more just your infectious arthritis. You can have just a localized infection where maybe I wouldn't classify it as osteomyelitis that causes a periosteal reaction, but it's a sign of infection. I did mention there are some malignancies that can cause that as well, but the most common thing to do that is infection. If it's a joint and you have these other signs of arthritis, that's a good indication that it's infectious arthritis. So a lot of times there's kind of a known source of infection, but sometimes there's just a blood-borne infection. And sometimes kids can get this chronic infectious arthritis, or we've shown you there's chronic osteomyelitis in kids that can just kind of, for some reason, it seems spontaneously occur, but they get infections within the blood. All right, any questions about these? That's the idea, is it stops the progress. And so I've had a lot of radiographs of my spine. Every year, a couple of years, I get more, and they want to see if it's progressed. And it progressed, because if you didn't stop the progress, eventually my whole spine would be ankylosed. That's why they call it what it is. I get these osteophytes that would then merge, and they call it bamboo spine. Fortunately, mine I caught early on, and my spine looks pretty good comparatively, so I'm not doing too bad. I have really mixed feelings about pharmaceuticals because, that was like a miracle for me. The fact that I'm even up and walking around and able to exercise is pretty neat. But a little thought for you guys that are Harry Potter fans. I'm not a huge fan, of course. Started watching them again when my kids are getting to that age where they're reading the books. But I've decided I want to model my teaching after Barty Crouch. So he was in disguise as this teacher. What's his name? Mad Eye Moody. He was actually a psychopath. Anyway, look that up. I found a pretty cool thing from Reddit, someone talking about how good a teacher Barty Crouch was. He teaches them about, I won't go too much into it, that's probably enough already. But let's do our first Kahoot. All right, first one's just a poll. And the reason I chose this background, who's gonna win? For those of you not invested in it, you have other choices. But that is the correct answer, hopefully. In fact, I was going to teach the 11th. I said, well, just in case BYU loses, I'm not going to be in a state to teach on a Monday. So move me to Friday. So we'll see. All right, which image represents a compound fracture? There we go. Let's see, I don't see the image. We're up here. Yeah, broken skin is what indicates compound fracture. Niha. Good job. Fast fingers. I don't know if this is the fake Teddy or real Teddy or what. It's hard to say. Which one is a pathological fracture? I'll give you a hint, being young is not pathology. So the answer was, yeah, D, none of the above. So yeah, osteoporosis fracture could be considered pathologic. I typically think of some lesion that weakens the bone. You know, you've lost a lot of the bone structure, and that makes it more susceptible to fracture. Actual real Teddy jumped up there. All right, what about comminuted? Minuted. Chose the wrong one. Can you fix it after? Once you choose, you're locked in. All right, yeah, last choice left is C, broken into 2 or more segments. That's your comminuted. Oh, close here. I have no idea. That's actual real. All right, what about image A? What do you call it? Now you got to type it in. Oh no. Young patient, undeveloped carpals, open growth plate. These ones were accepted. Oh, that didn't. Oh, 0 shows that. These are the correct ones that I put in as correct answers. Green stick is the answer. Not much change. Seems like it's not updating. It's like frozen here. All right, what's the appropriate average timeline for the reparative phase? So we said first couple weeks was inflammation. Maybe I said 3 to 8 weeks, but after that, you know, weeks to months, that's your reparative phase. So B was correct, or blue was correct. Several months to years, that's more your remodeling phase. Yeah, remodeling is the long one. Yeah, you thought you'd missed it. True or false, there are 3 phases and 5 histological stages. Slide might help. Well, still, if you have to read the slide and you're sitting there reading it, you're going to get behind and miss points. So sure, just memorize it. Y'all have eidetic memories, right? Just memorize the picture. So yeah, 5 histological stages, 3 phases. So however they classify it. So not a lot of changes. All right, now place these in order, the 4 histological stages, 4 of the 5. I used to teach a mnemonic to remember this, and it was, hey, Granny, call lamellar remodeling. If that helps you remember. Most of you got it. Hematoma is the first day, granulation, first couple of weeks. Then after that couple of weeks, you get that callus formation. Weeks to months is your lamellar formation. Yeah, still in the need. Is Kevin getting married? You sound reluctant. Yeah. 4 cases of non-healing we discussed, or 4 causes of non-healing are interposition, mobility, infection, and what? Ischemia. Oh, most did get that. Ischemia is correct. This one looks more like maybe interposition of soft tissues. Staying the same here. Someone's gillyweed. All right, which of the following correctly identifies 4 of the 6 radiographic signs of osteoarthritis? Big hint here is look for the one that doesn't have what? So 3 of the 4 have pannus in it. That's correlates with, that's the inflammation, the granulation tissue in rheumatoid arthritis, not in osteoarthritis. But reduced joint space, erosion, subchondral cysts, and osteophytes are all in arthritis. All right, got a little change there. Which of the following is considered inflammatory and contains a pannus? You probably already know the answer. A lot of new choose. Most did get that. That one is the rheumatoid arthritis. No changes. Pseudogout or chondrocalcinosis is a disease of what type of crystal deposition? Like my image. Someone creating a certain type of crystal there. Yeah, calcium pyrophosphate. Okay, nobody chose these other ones. Uric acid was for gout, but pseudogout or chondrocalcinosis is calcium pyrophosphate. A couple people came up here. John and bought diff. Which image likely represents pseudogout? That was more the crystal-like deposition. Looks more ground glass. This is more particulate. Which is B? What disease? Synovial chondromatosis. Synovial, like synovial membrane. Chondromatosis. And then what's C? What? Joint mice. You see it in your head, the dancing mice. Oh, here we got some changes. Kevin's best man and John moving up. Which image here likely represents synovial chondromatosis? I guess I shouldn't have given those away. Forgot I asked about both of these. Nice. Little movement there. Guess I asked about all these, I forgot. Trying to get us move on quickly. Just choose C and let's go. There we go. It was C. Yeah. So no changes at the top there. What is least likely of these diseases or conditions to cause fatigue and fever? Good, osteoarthritis. Yeah, the rest are more infectious or inflammatory. In the case of rheumatoid, that can cause fever and fatigue. Should I give you a big hint? Because I looked through the assessment, I thought one question is a little tricky. There's one question a little tricky. You really need to know symptoms of Lyme disease. Or fatigue and fever a symptom? What else? What are the other symptoms of Lyme disease? Chills, maybe. That goes along with bullseye rash, malaise. What about nausea? Not so much known to cause nausea. But all these other ones that you just mentioned, yes. So no changes there. There's silence all of a sudden as everyone's writing. That was a tough one. But now it won't be, at least for those who attend. Which symptom of Lyme disease will likely occur last? Remember the timing? We said the late one of the late ones was arthritis. So we're talking about Lyme arthritis. This whole lecture's on arthritis, or a lot of it is. And that was the later one. This is early. This is what we call it disseminated. So that's more after the first month, right? But this is several months later. Facial palsy was also in the disseminated. We had an image of someone with facial palsy there. Yeah, most of you got that one. Oh, why doesn't it do the big... It just goes right to that slide. I don't know why it does that, but Kevin's best man, who was that? Took over the lead at the end. No one wants to admit. Okay. You can stay incognito. Not sure which Ryan this is. It is you. The only one that's here? Oh, okay. All right, let's take a 10-minute break. Come back at 9:50 and get started on the next half of this. All right, now we get really into the Mr. Glass portion of the lecture as we talk about what he had, among other things. So I find this stuff interesting. I know you guys, you've had a bit about the vitamin D pathway, calcium, phosphate. I'll try to kind of solidify how that works because it's important for understanding how these diseases work, what happens. Don't expect you to remember everything really, but some of the lab values I do want you to know. And so we'll kind of take this in chunks. Remember, I think I did go over this with you in oral path 2. So hopefully it's somewhat familiar. But first I want to talk about vitamin D metabolism. How important is this first step? How important is UV light radiation to getting adequate amounts of vitamin D? It's actually, I think our text, I think the radiology text says it's responsible for 90% of your vitamin D. To some degree, you can get a lot of vitamin D from dietary sources, but for most people, you need to supplement that with some sunlight exposure. That goes against what your what your skin doctors are going to tell you, right? But we'll go into this, some of them. And so that converts the 7-dehydrocholesterol into cholecalciferol, or vitamin D3. So that converts it into the same type of vitamin D that you get from most dietary sources, your fish, your eggs, or a lot of things are fortified with more vitamin D, and that can help. But yeah, according to our text, a small amount is gained from dietary sources. But that is still more, that's not the active form, right? That's not the form that has an active effect on the metabolism of bone, on us maintaining enough calcium, because that's really the primary effect of this active vitamin D, is retaining enough calcium and phosphate from our diet so that we have sufficient calcium. And for that to occur, that has to be hydroxylized first in the liver, one step. And so that changes from this vitamin D to 25-OH vitamin D. And so that's 25-hydroxylase that does that in the liver. So you have to have a healthy liver, but you also have to have healthy kidneys, because then it hydroxylizes at that first site, the 1-hydroxylase. And then this is the active form of vitamin D. And so, I forgot about all my graphics. You got to get some amount of UV light. And how's the sunlight right now? If we go outside, how much vitamin D are we going to get from the amount of sunlight? It's about the middle of the day. Actually, for how far, what's that called? Your parallels, how far parallel we are north, there's probably right now not enough to get a significant amount of vitamin D conversion. So you got to do this in these northern locations like we're in now. We're not as far north as Idaho, or obviously, or some of these other ones. But you get a lot better in the summer. And so I'm going to talk more about that. But yeah, we need healthy liver, we need healthy kidney to get the active form of vitamin D. Hydroxylases. And so what's the function of vitamin D? I said the primary one is this green arrow here. So you see the plus. It's promoting calcium and phosphate absorption in the intestines, so from the food we get. It also decreases the renal excretion. So that helps us hold on to it and not excrete it in the urine. So the way it affects the kidneys. It promotes bone mineralization. And the way our book, the radiology book, is where I got most of my things, as you know. The way it words it is a little bit deceptive, I think. It does have an effect on osteoclasts, and it does have an effect on bone resorption, but you can think of it as more healthy bone turnover. So it actually, the net result of having healthy amounts of vitamin D is having healthy, strong bones, right? Because it helps that, first of all, have enough calcium in the system, in your serum, but then also it helps with that healthy bone turnover where you're depositing those minerals, the calcium and phosphate, into the skeleton. And one of the things you probably learned about in the skeleton already is it's a reserve of these minerals, primarily calcium and phosphate in our hydroxyapatite crystals. And so it's all healthy and promoting good, healthy skeleton formation or bone formation. It does inhibit itself, so it has this inhibition effect on the kidneys. So that final step, that 1-hydroxylase, if there's plenty of vitamin D that's active in the system, it prevents your body from creating more of that. So as with most hormones, they do have a self-inhibitory effect. And I was reading about it, actually, we do have quite a bit of this 25-OH in the system. This is actually in your serum in high amounts, and this is in a lot lower amounts. That's one reason they test for this and not this, and I'm going to talk about that a little later. And then the last thing we'll talk about with vitamin D is there's an inhibitory effect on PTH, parathyroid hormone, in the parathyroid glands. This looks like it's just showing the thyroid gland itself, but you do see these little tiny, if you look really close, yellow dots. That's on the back of the parathyroid gland here in the throat. And those are on the back of the thyroid gland, those are the parathyroid glands. All right, questions about vitamin D, function, metabolism? Next thing to know then is it not going on? PTH, or parathyroid hormone function. The way I remember this one is PTH is kind of the calcium Nazi. You think of the soup Nazi from Seinfeld. It ensures that you have adequate amounts of calcium in the serum. Why is it important to have adequate amounts of calcium in the serum, in your blood? Yeah, it's important for neurons, important for muscles, important for basically every cell in your body, it uses calcium. And so your body closely maintains or tightly maintains calcium levels. And the primary way it does that is with parathyroid hormone. We just talked about the skeleton being kind of a reservoir of these minerals. So you have a reservoir of calcium in your bones. And if you need more calcium, as soon as calcium starts dropping low even a little bit, that stimulates PTH formation. So this dotted line means kind of an inverse reaction. And so low calcium is going to increase PTH formation. It's kind of the big primary factor. What that does is it increases bone resorption, right? PTH has a direct effect on bone to draw that calcium out of the bone. So to draw it out of the reservoir that we have in bone and put it into the serum. It also promotes, so ignore this one for now. We're talking about the healthy kidney here. This is diseased kidney, so kidney failure. But it has a positive effect on promoting hydroxylation into that final form of vitamin D, which that'll also help. As we just showed, vitamin D has a positive effect on retaining more calcium and phosphate from your food, so in your intestines. So it's doing all these things to try to maintain a healthy level of serum calcium. Also increases the reabsorption of calcium in the kidneys. So you're not expelling as much calcium, but it actually expels more phosphate. So the way I think of this, whether this is accurate or not, I think of it as retaining as much calcium as possible at the expense of phosphate. So it is actually increasing phosphate more. Even though it's drawing both out of the bone, one of the results of hyperparathyroidism is you're drawing more calcium out of the bone. It's doing all these things to increase calcium levels. So that's the one thing that causes increased calcium levels, but it's also kind of excreting more phosphate. So you have lower phosphate levels in hyperparathyroidism. All right. And then in health, so if you don't have hyperparathyroidism or something just continuously causing more parathyroid, it should function in that the raised calcium level is going to then inhibit more PTH production. So as we know, with all hormones, there's always these differing effects to try to control each other. There's inhibitory effects so you don't get too much PTH. Any questions about that? A lot to remember. We'll go through some examples of this. And as we talk through these different diseases, talk about why they are the way that they are and how you get there. Why certainly these hormones are higher than others. All right, here's our soup Nazi. That's how I remember PTH, parathyroid hormone. Primary reason for PTH is to ensure enough calcium in the serum by taking out of bone, increasing reabsorption in the intestines, also in the kidneys, and also vitamin D creation in the kidneys. So everything about it is to maintain higher levels of calcium. You need to know a little bit about alkaline phosphatase. This is an enzyme. If you just Google alkaline phosphatase, it may tell you that it's something found in the liver and something that may be high in liver disease. But it's also an enzyme that's important for bone formation. It removes phosphate that makes it available for osteoblasts, to lay down more bone, to lay down the phosphate in the mineralization as it's creating the hydroxyapatite. So it's an enzyme. It's important for bone mineralization. And really anything that causes increased bone turnover can have higher levels of ALP. You guys remember the one I told you from Oral Path 2 to remember for when you have high ALP levels? That always comes up in board review questions. If everything else is kind of normal and you have super high ALP, the one to remember is this in yellow, it's highest in Paget's disease. So yeah, I just explained how it's an enzyme, so it's released during osteoblastic activity as it's turning over more bone. So yeah, by far the big thing to remember, it's highest in Paget's disease, but it can also be high in a lot of these other diseases. Yeah? You have a question? No? Oh, okay. So we'll talk about all these ones too. Well, not all of them, but Rickets and Osteomalacia, hyperparathyroidism. But it can also be high in multiple myeloma, which I kind of think of really similar to, well, if you had a bone malignancy, which myeloma is it's settling in bone, you can increase the ALP levels. But any bone malignancy or metastases to bone, even some cases of fracture healing, because you've got increased osteoblastic activity, when a fracture is healing, they may have raised ALP levels. But none of these are going to be as high as it is in Paget's disease. So with that, that was our hormones and how things work. Let's talk about osteoporosis. Just an overall decrease in bone mass or bone mineralization. So bone mass does increase as we age until the age of 30. And then the imbalance of deposition resorption leads more to bone loss, which is on average about 8% per decade for females and about 3% per decade for males. Osteopenia, this is not a diagnosis, but more a description. So if I see something that looks osteopenic in a radiograph, I could describe it as osteopenic. It probably would be inaccurate to describe it as osteoporosis because I can't diagnose that just looking at a radiograph. To really diagnose it, they've got to do the bone scans or these DEXA, dual energy X-ray absorptiometry. And it has to be 2.5 standard deviations below what's accepted as the peak bone mass. So it is something that requires a specific diagnosis. But obviously, if you see someone that look really osteopenic, probably a safe bet that they have osteoporosis, especially if they have these, an older patient. Remember me talking about osteoporosis, how the external oblique ridge really stands out. You'll get kind of a reduce in that thickness of the inferior cortex of the mandible. And so that's your typical osteoporosis. Here we see those same signs. The bone looks more glass, more translucent or transparent, radiolucent. The external oblique ridge really stands out. Maybe to some degree you have decrease of the thickness of the inferior border of the mandible. Kind of loss of that marrow space, just overall radiolucent bone. A lot of these other diseases we'll talk about can cause that. I talk about hyperparathyroidism as being more of the ground glass appearance, but in oral path, I really just wanted you to recognize that it's a systemic condition because there's an overall radiolucency of bone, because it's tough to really distinguish what causes that. Of course, if it's an older patient, specifically an older female patient, good chance that it's just going to be osteoporosis. So the different risk factors for osteoporosis, and you should probably remember these ones: age-related, right? Reduced physical activity. So really important as we age to maintain physical activity, not just for muscle tone and development, but also that helps with bone, right? The more bones are under stress, they're more going to be prompted to remineralize and maintain the mineral inside the bone. Genetic factors have an influence. Calcium nutrition state. So we just talked a lot about vitamin D. And so vitamin D, we talked about how that influences calcium. So either vitamin D or calcium, if you're deficient on your nutrition for either of these, that's going to lead to loss of bone mass, loss of mineralization within the bone. I just talked about sun exposure, right? If you're exposed to sun, that can, during growth, that can actually increase peak bone mass. And then as we age, probably want to get some sun, so we maintain the vitamin D levels, providing a buffer against osteoporosis. And then the last one is hormonal influences. And the last slide, we just talked about how women lose bone more rapidly than men. We're on an average of like 8% per decade for women, 3% for men. Some of that may have to do with hormonal influences, so estrogen deficiency in postmenopause. All right, so what's rickets and osteomalacia? If you remember from oral path, that's your vitamin D deficiency. Rickets in children, osteomalacia in adults. For rickets, this is one of the kind of key features, the bowing legs. Maybe they don't always get that. But just that vitamin D deficiency, what do we say about that with mineralization of bone? If you're deficient on vitamin D, you're not resorbing enough calcium. Even if you have adequate in your diet, you need vitamin D to resorb that from your diet. And so there's not enough calcium available while these bones are growing, and they tend to be deformed, bowed outward. Interferes with deposition of those growth plates. Osteomalacia is when it's in adults. And so that would be more kind of like accelerated osteoporosis because of lack of vitamin D. What do we see in this radiograph? I mean, you can barely see the bone here. It's lost so much mineralization. I can't necessarily tell that that's from osteomalacia, but it just looks like a very severe osteoporosis, very severe loss of bone mineralization. In osteomalacia, it can also cause Symptoms, it can cause bone pain, predisposition for fracture, as you would expect with loss of mineralization. Here's some of the other signs of vitamin D deficiency: mood changes, muscle weakness, cramps, hair loss even, fatigue, bone loss, joint pain. I want to ask you guys, how common do you think vitamin D deficiency is? I kind of went into the weeds this last week looking into this, and it probably delved way too much into this. And I mean, I knew it was a problem, but not, has anyone looked at this link? Someone pull up that link and tell me how many people, I guess, throughout the US have vitamin D deficiency. Or just throw out a number, what do you think? Percentage. Not 80. 80% of a certain population. Interesting you say that. 40 overall. But what does it say here? Dark-skinned people at 15 to 20 higher risk of vitamin D deficiency. It's about 80% people with dark skin in the US are going to have vitamin D deficiency. So this is, like I said, I kind of delved too much into the weeds, but it's interesting. Melanin protects from skin cancer, right? But there's trade-offs here. It also blocks UV rays from forming that pre-vitamin D. So dark skin would require 10 times as much UVB radiation to produce the same amount of pre-vitamin D. So we all need more sunlight, I think, in general. Also linked to, there's tons of studies. Maybe one of the reasons I'm biased on this is some of these studies are done by this guy from Boston University, and he's the guy that taught me when I was in your shoes and in dental school and learning about, the pharmacology and the biomedical stuff. This guy is a strong advocate of vitamin D. You can look him up, it's Michael, now I forgot, Michael something. But yeah, it is a pandemic. And it's kind of, I was even surprised at how much under-recognized it is. So get your sunlight, that's the takeaway. Not enough to burn yourself. All right, so what happens with vitamin D deficiency? We talked about the pathway, we talked about the metabolism. So if you're low on vitamin D, what's not going to happen? The primary thing we said for vitamin D is it influences resorption in the intestines. And so you have deficient calcium and phosphate being absorbed from dietary sources. So that leads to a lower calcium level, hypocalcemia. If you have, as soon as this starts going low at all, we said PTH was the calcium Nazi. It sees this going low and you start to increase PTH production. PTH production very strongly increases bone resorption. It's drying the minerals out of bone so that you can have adequate calcium. What ends up happening with vitamin D deficiency, calcium might be slightly low, but it's so tightly maintained, it can be normal. Phosphate is low. Remember PTH, it was holding on to calcium as much as it can, but excreting more phosphate through the kidneys. And so phosphate is low. But phosphate being low, that leads to reduced bone mineralization. I mean, you don't have sufficient calcium, you don't have sufficient phosphate to maintain your bone mineralization. And so the overall result, if you have long-term vitamin D deficiency, that's why you get your osteomalacia and you get very radiolucent bone, you're losing mineralization. All right, so what are the lab values going to be? For Rickets osteomalacia, what do you think calcium will be after what I just said? Could be low, but it's so tightly controlled, it might be just barely low. May even be normal, may even be within the normal range. So low to normal calcium. What's PTH going to be? High. Yeah, that low calcium is stimulating more and more PTH production. And you're not getting enough calcium. It's consistently low, and so you have high PTH. What about phosphate? Yeah, low, we said PTH is stimulating the kidneys to excrete phosphate. So phosphate is low. According to the, let's see, first aid for INBDE, they kind of had variable for that one. But you can imagine there are different factors affecting phosphate. There's increased bone resorption. That's getting more phosphate out of the skeleton into the serum. And so that could potentially increase phosphate, depending on which one wins out. So that's why it might be variable. But I think most texts talk about phosphate as being low for osteomalacia. Then alkaline phosphatase, it could be high. Yeah, whenever you have increased bone turnover. Is it going to be as high as in Paget's? No. There's our penguins in Madagascar. They're correct. You got to get that vitamin D. So how can you get it? Egg yolk, saltwater fish, liver. Anyone eat liver? I don't think anyone does. But mushrooms, or there's fortified foods. A lot of foods now are fortified with vitamin D. So these things can help. But I'm an advocate for getting outside and getting some sunlight during the summer. I got my legs tan this summer more than I ever had it in my life because I've been running so much. But all right, here's a thought question for you. And you've seen it before, if you remember. Is this rickets or osteomalacia? Rickets, because it's a young patient. Rickets can affect tooth development. So if this is occurring when teeth are developing in a really young patient, that's what rickets is. You can see it almost looks like amelogenesis imperfecta, but this is from a vitamin D deficiency. So things that affect bone formation, if it's occurring while teeth are developing, it can also affect tooth formation. And so rickets can do that. And that can lead to delayed eruption, malocclusion. We see these enamel defects, even dentin defects, increased caries because they don't have enough mineralization when these teeth are developing. All right, I'll talk briefly about scurvy because this comes up on your board review stuff for this material. I think of it more as typically a soft tissue thing, which I tend to avoid, right? I'm your radiology guy. I only deal with hard tissues. Always reminds me of Pirates. That's why we have Johnny Depp here. Scurvy is a vitamin C deficiency. It can affect bone formation though, because it affects collagen, and specifically your type 1 collagen, which is the common one. And that's what's required for osteoid formation. And so if you have impaired osteoid matrix formation, you're going to get impaired mineralization in the bone. But the other more common things I think of with vitamin D deficiency are going to be your bleeding gums, periodontal disease, right? Petechiae in some cases, so little small skin red patches, red splotches. But yeah, it can lead to osteoporosis because of that impaired osteoid formation because of the collagen effect. This one I like, so I'm talking a lot about the parathyroid function. What causes hyperparathyroidism? Typically, it's not autoimmune. It's usually I don't know if there is a form of autoimmune, but in most cases, it's a tumor of the parathyroid glands, typically a benign tumor. I think it's like 85% of the time, it's a benign tumor of the parathyroid glands, which just continually stimulates parathyroid hormone. So what happens if you have some tumor that's just constantly stimulating too much PTH? What's that do to your calcium? You start bone demineralization, it's drying it out of bone. That increases serum calcium. It actually stimulates formation of the active vitamin D, which increases calcium retention in the intestines, but also in the kidneys. So all these things are acting together to increase calcium levels as well. And so this is the one disease where you can have high PTH and high calcium. Because in any other case, as soon as you get calcium going up at all, it has that reverse effect on PTH. And PTH is gonna go lower. And actually it's the one thing that probably in 90% or more of cases of hypercalcemia, it causes it, is hyperparathyroidism. This is what we just went through, bone resorption, reabsorption in the kidneys. Let's see, didn't mention in the intestines as well, but we talked about it. Yeah, it's the vitamin D effect on the intestines. And then these are the symptoms of hypercalcemia. And because of that, it's also the symptoms of hyperparathyroidism, because as this shows in about 90% of cases of hypercalcemia, they're caused by primary hyperparathyroidism. There's also secondary hyperparathyroidism. But so stones, you have increased calcium in the serum. It can lead to kidney stones. You're drawing it out of the bone, so osteoporosis, osteobone lesions. What are these bone lesions called? I mentioned earlier. The bone lesions from hyperparathyroidism. What can brown do for you? If that helps you remember, I don't know. Yeah, those are brown tumors, specifically in hyperparathyroidism. It can cause abdominal pain just because of the effect of calcium on all the different cells in your body. Malaise, lethargy, polyuria, so having to use the bathroom a lot, increased needing of increased thirst, needing to drink. Psychiatric overtones, so confusion and memory loss. All these are results of high calcium in the blood. And so what are the lab values then for hyperparathyroidism? We just said all those were from hypercalcemia, so calcium is going to be high. What's PTH going to be? High. You could stop there and say, I just gave you that those two being high are pathognomonic for hyperparathyroidism. In any other disease, any other condition, those are going to go opposite, your calcium and PTH. All right, phosphorus, what do we say for that one? Yeah, that typically low, although the INBDE first aid book says variable, but more often low. Alkaline phosphatase, we said a lot of these, it can be high. Anything that causes kind of that increased bone metabolism, ALP can be high. And so don't think just because you see high ALP, it has to be Paget's. But it's super high in Paget's. So that's a good way to remember. High PTH. So yeah, think of this guy. If you see both of those, it's slam dunk. You can celebrate. How would you describe this? Ryan, yeah. Ground glass, is it localized or generalized? Generalized ground glass, so you're thinking a systemic type of condition, maybe one of these metabolic or other type of systemic condition. Ground glass specifically, I think of more with hyperparathyroidism, but this could easily be one of these other things that we'll talk about. This could be renal osteodystrophy. If you see specific areas where it looks like localized radiolucent tumors, more likely hyperparathyroidism because those are your brown tumors. I don't necessarily see that here. Maybe you could argue in the anterior maxilla. But yeah, very significant changes. Anyone feel like this? I never make my own memes, I just find them. So this one as well, same thing, kind of a generalized, it looks overall more radiolucent if you see how much the teeth stand out, but also a generalized ground glass appearance. And for whatever reason, hyperparathyroidism is the first thing I think of, especially when it's at ground glass. Very different from osteoporosis though, right? You've kind of lost the cortical borders all over and just way too severe for osteoporosis. You could have a really severe osteoporosis, but okay, other changes. What do we call these? Brown tumors when you get specific lesions associated with hyperparathyroidism. And then there's a specific name, and this keeps coming up on board review material. When you have this overall radiolucent appearance and a lot of these brown tumor lesions, a lot of these specific lesions, they'll call that osteitis fibrosa cystica. So know that that's related to brown tumors. Know that it's related to hyperparathyroidism, both of those. Okay, 85 to 90% of primary hyperparathyroidism is caused by a benign tumor on the parathyroid glands. So a parathyroid adenoma. A smaller amount is just from a hyperplasia, so just from an overgrowth of the glands, even though it's not necessarily a true tumor. And then even more rare is going to be a malignant tumor of the parathyroid glands, a parathyroid carcinoma. There are diseases that are kind of classified as secondary hyperparathyroidism, but we'll talk about those in a second. We talked about vitamin D deficiency. So vitamin D deficiency, it can lead to what? What does vitamin D deficiency do with calcium? We said lower calcium. And so that can increase your PTH. And that's what causes the secondary hyperparathyroidism. But does that cause higher calcium? No, we just said it lowers calcium. That's what's causing the increased PTH. So yeah, that's going to be your secondary, and similar with renal failure. We'll talk about that one coming up. In fact, that's the next topic, kidney failure. So what happens with kidney failure? Your kidneys are kind of needed to function properly to hold on to as much calcium as possible. They're in your kidney tubule, you just learned about that probably, maybe, I guess sometime. I don't know when you learn all this stuff. But those are retaining calcium, or yeah, they try to retain calcium, but it requires functioning kidneys. But phosphate is actually expelled by a functioning kidney. And so if it's not functioning, calcium is going to be decreased, and phosphate actually starts to build up in the serum. If you start to lose calcium, what happens to PTH? It's upregulated. One of the first things that happens, right? So increased PTH. I wouldn't worry too much about this. Have this little expanded section here talking about the effect on osteoclasts and differentiation. But glucocorticosteroids play a part. Really, all that's saying is, my takeaway from this is it's leading to bone resorption, right? Because you have decreased calcium, you have that increased PTH, it's just resorbing more of the calcium from the bone. All right, so we just said that can be a cause of secondary hyperparathyroidism. Your PTH may be high, but in any of these cases of secondary hyperparathyroidism, the calcium is low, and that's what caused it in the first place. Osteomalacia can do the same thing. Or no, sorry, this is saying osteomalacia. They may call it osteomalacia secondary to renal disease. Kind of like they call it secondary hyperparathyroidism, they could call it secondary osteomalacia. But it's not necessarily due to a primary lack of vitamin D in the diet or vitamin D exposure. All right, on to our congenital disorders. Here's our Mr. Glass disease. Osteogenesis imperfecta, brittle bone disease. I mentioned this when I was talking about dentinogenesis imperfecta. And depending on the source, some books talk about people with osteogenesis imperfecta as 25% of them having dentinogenesis. Another book says 50%. So I don't know, I guess on average, you could say about a third of these patients will have dentinogenesis imperfecta. They also have blue sclera. So the white of the eye tends to look blue. All this has to do with a defective formation, again, of type 1 collagen. So we were talking about vitamin C deficiency. Vitamin C is needed to form proper collagen, but this is a defect in one of the proteins to form that type 1 collagen. They have extreme skeletal fragility, so very prone to fractures. Has everyone seen at least the movie Unbreakable? That was the first of these series. They have Unbreakable and Split, and then Glass is the last one. Mr. Glass is also in Unbreakable, and that's where he talks about his disease. Let's see, anything I missed here? It affects the skin. Skeletal deformities is 2. Osteopenia, that's what leads to these fractures. So very prone to fractures. Here's his quote from the movie Unbreakable. Figured I put it in here because he talks a little bit about the condition. He doesn't make a particular protein very well. It makes his bones very low in density, very brittle, easy to break. There are a lot of different versions of the disorder. He talks about type 2, 3, 4. He has a little bit off here. There are 8 types. Type 2 is actually the most severe. That's the autosomal recessive one, and they usually die within the first year. I think I saw similar stuff on board review material. So yeah, I changed this to 25 to 50% because depending on the source you look at, half or a little under half are going to have dentinogenesis imperfecta. If you don't remember dentinogenesis imperfecta, go back and study that. And amelogenesis imperfecta, those are really common ones for boards. For dentinogenesis, it has a constricted cervical region, more of these bulbous crowns. Looks like it's affected the pulps as well. This one you have to look really closely. It has these really thin roots. But again, the constricted cervical region of the teeth, very bulbous crowns. That's your dentinogenesis imperfecta. Clinically, these are going to look almost radiolucent. So they'll call this opalescent dentin. And then in the oral path 2 slides, I included one picture of Mr. Glass where they just kind of painted his teeth black. So it didn't really look like this, but I think they were trying to make it look like he had a tooth deformation. But yeah, it really looks more opalescent, sometimes tannish in color, sometimes more bluish, blue-gray. Any questions about osteogenesis imperfecta or Mr. Glass disease? Then we have osteopetrosis, which is kind of the opposite. It's a failure of osteoclastic acid activity. So osteoclasts are not removing bone. So it actually gets too mineralized. It's just osteoblasts working, think of them not really working overtime, but by comparison, osteoblasts are laying down more mineralization, and osteoclasts are not working. And so they become very dense and stone-like, but think of it like chalk. So to have the strongest bone, I mean, there's a reason it's like a composite. You have a good cortex on the outside, you have marrow space on the inside, and with a good composite, there's a trade-off between being too brittle and not enough malleable. And in this case, they're not malleable enough, and they're also prone to increased fractures, even though it looks like they have really dense bone. Maybe not quite as much as osteogenesis imperfecta, but they also have increased fractures. What's going to be the effect of having decreased marrow space? Now, if the bone is just totally mineralized and you don't have marrow space, what's the function of marrow? It creates your, what's that? It produces white blood cells, like everything that fights infection. And so they're going to have a lot less of that, and they're going to be more prone to infection, anemia. Yeah. It can narrow cranial nerve formation, could lead to blindness. So again, just like with osteogenesis imperfecta, there's different variations. And if you have the very severe, autosomal recessive one, it can be fatal. That's your severe infantile osteopetrosis. I think they're pretty easy to distinguish radiographically. This, if you just look at one area, this could easily be a chronic osteomyelitis, right? Osteomyelitis results in really dense bone, but this is more generalized throughout the whole mandible. Maybe you can appreciate a little bit in the maxilla as well. They do have signs of osteomyelitis here as well, but they're more prone to infection, right? As we just talked about. They don't have marrow space. This bone's not going to heal as well. They had an extraction here. So that I don't necessarily see sign of a fracture. Maybe this looks like a little fistula. But there's a periosteal reaction. And so they have a non-healing bone here just because they're more susceptible to infection. Delayed eruption of teeth because that bone is so dense, or they may not erupt at all. May lead to hypocalcification and carious teeth. So just not properly formed teeth as well. Prominent canals, just because the bone's so sclerotic, you see the inferior canals really stand out. And Paget, mentioned over and over, this is the big one where we say really high ALP. So it's also called osteitis deformans. This was a lot more common like in England, British people. And this is an abnormal osteoclast activity. So going to be kind of similar to osteopetrosis, but then it occurs later in life. But there is kind of a mixed appearance to these. So there's some degree of osteoclast, osteoblast, and it's kind of really affecting the formation of the skull in this case, or anywhere in the skeleton. It tends to occur in the spine, pelvis, skull, femur, but you'll see this on occasion in the jaws. And so I'd say this was a new one to me. They are predisposed to osteosarcoma. The big thing for this is cotton wool appearance, radiographically. Almost looks like clouds, like a cloudy appearance. That's similar to what I would call as a cotton wool appearance. So if it does involve the jaws, it's going to be similar to the skull. The bone is actually increasing in volume. And so it affects the skull a lot. If someone's head is growing, I mean, it's not going to be so much, it's completely obvious, but their hat's not going to fit anymore. And if it's in the maxillary mandible, their dentures may stop fitting because that bone is actually growing in volume. It's expanding. It's associated, for whatever reason, a lot with hypercementosis. So a lot of these teeth, I don't know if we see any here, that looks like it has some hypercementosis. And then it also affects ability to fight infections, so they're more susceptible to osteomyelitis. All right, what do you think about the other lab findings? Most of these will actually be normal. And so if they're normal or close to normal, and the ALP is just skyrocketingly elevated, it's probably Paget disease. Yeah, normal PTH, normal phosphorus. Maybe one of these will be slightly low, but what's that? Know that the ALP, if it's just off the charts, skyrocketing, here's your little reminder for that. If it's a large number, think Paget's. All right, other bone lesions or bone conditions, I should say, because some of these aren't, this one's not necessarily a lesion, right? We talked about achondroplasia as the most common form of dwarfism, abnormal or delayed growth of cartilage, achondroplasia being the most common one. This is the one where they have normal torso height or size, but then the long limbs are shortened. Normal size head, normal size trunk and torso. In the oral cavity, they may have mandibular prognathicism. Here's a couple of famous celebrities that have it. Peter Dinklage, who I know from Elf. And then, what's his name? Wee Man? Jason Acuna. I had to look up his name. All right, you know osteomyelitis, hopefully. All right, sequestrum, periosteoreaction. Sequestrum, the book talks about hallmark of osteomyelitis. A lot more common in the mandible because of that, because there's less vascularization. The maxilla gets a lot more blood supply, so it's less common to get osteomyelitis. Chronic, long-standing, lots of blood supply, right? Necrosis of bone, although some of the books talk about necrosis and sequestrum as being more of an acute sign. So I'm not too worried about acute versus chronic. What I think of acute versus chronic is it more resorbing, and that's more the acute stage, or more the sclerotic, and that's more the chronic. And so these are pictures, I believe, just from our radiology book. What do we have here with the black arrow? And what was this one? Periosteoreaction. So you should recognize that immediately as osteomyelitis. This one they describe more as chronic, but all these I see kind of a mixed, right? I'm only going to really focus on acute if it's just completely radiolucent and looks like malignancy. When you see that chronic, that sclerotic border around it, that's chronic. This one also I see chronic, but they called this one acute. So I don't know. But there is a sequestrum here. Let's see, this one I would more call an acute because it looks more diffuse. This looks like a malignancy, doesn't it? Ill-defined, invasive, irregular borders. That's your acute osteomyelitis. And then remember osteonecrosis. There's going to be a cause for osteonecrosis, right? Either radiation induced because they've had therapeutic radiation because of a history of head or neck cancer. So where this very high dose radiation, thousands of times higher than any diagnostic dose, is going through the tissues. That causes radiation changes, and in extreme cases may lead to necrosis. That's what we'll call osteoradionecrosis, or medication related when they've taken bisphosphonate, or in some cases these newer anti-angiogenic agents that can cause it. In pharmacology, did you go over everything that can cause that? So what is it mainly that does it? Bisphosphonates, and specifically IV bisphosphonates. Why do people take bisphosphonates? You could take it for osteoporosis, probably not the IV one, maybe if it was really severe. But certain malignancies, what else? Do they take IV bisphosphonates for osteoporosis? Oh, I thought it was more just the oral. Okay. So yeah, just correlate with a history of bisphosphonate use. This is something I think I took out a couple years and I've put back in because it is in board review material. It's something pretty rare, and I think it's something weird to come up on dental board review material. It's these specific areas that tend to develop avascular necrosis, usually in children, because it's growth centers of bone. This is unknown etiology, so it's also a necrosis. So it's going to be really similar to an osteonecrosis, right? The bone is dying. But this is more unknown cause, but it happens in certain locations. Let's see, one book I think only mentioned this one. So I think this might be more the classic one, Osgood-Schlatter disease, and that's the tibial tuberosity. So the top of the tibia, so it's going to be in the knee. Head of femur, so in the hip, that's Perthes disease. So in one of the tarsal bones, so inside the kind of the big part of the foot, that's your Kohler disease, intervertebral joint, metatarsal head. Yeah, most of these are equally as common in females or males, other than this one is more common in females. This one's actually more common in males. So Osgood-Schlatter, I think the typical appearance of this one is in adolescent boys who play sports for whatever reason. They get that one in the knee. All right, so you recognize this as a foot. You recognize it's a child. Kind of have a little pudgy foot anyway, but there's a normal navicular bone. You can see the growth plates. That's why you can tell it's a child. These bones aren't completely developed. And there's avascular necrosis of that bone. So that one was your Kohler disease. And then this one in the hip, I had other mnemonics for this as well. If you're really interested, I could tell you. I don't know if I remember all of them. But I think of someone walking around Cole's too often, and so they get it in their foot. That's Cole's disease. I don't remember how I exactly tied this together, but this is Perthes in the hip. And who is the actor that played Joker? Heath Ledger. He's from Perth, Australia. I don't remember how I correlated that with hip. Maybe he took his hip bone out and hit someone with it. He could do that. I can easily see him hitting someone with a hip bone. But then, yeah, for boards, I would say this second one might be a good one. I don't remember how I remembered that one. That one might come up. I don't know if any of these will come up on boards. It seems like such a strange thing to have on dental boards. Probably not going to be on my assessment for you. I'll tell you that much. What do you need to know as far as lab values? Hope you remember some of these. What can you remember from hyperparathyroidism? Two things should be high. High calcium, PTH. If those two are high, just stop there. That's pathognomonic. You got hyperparathyroidism. What else do I have starred? I think I started osteoporosis just because it's common, but that's kind of variable, right? These might be normal, might be low or high. What about rickets and osteomalacia? Think of low vitamin D. And then what's that going to do to other things? That lowers your calcium. I said, other than hyperparathyroidism, these should be flipped in most cases. Here's the exception, right? You can get hypoparathyroidism, which I didn't even talk about, but then you're going to get low both. And so that's just the opposite of hyperparathyroidism. Everything else, though, when you have functioning, let's see, functioning parathyroid glands, these are going to be opposite. So low calcium, high PTH. Rickets and osteomalacia, we said low phosphate. Now I don't remember the difference between these ones. So this is the one difference between, maybe on the next slide, I delineate that. So why is phosphate low in rickets and osteomalacia? I think I stated that, but now I'm drawing a blank. You got high PTH. Yeah, and that, okay, yeah. High PTH should expel phosphate if you have functioning kidneys. And here, there's no problem with the kidneys. This is the one difference here. With dysfunctional kidneys, you got kidney disease, renal osteodystrophy. It should be expelling phosphate. You should have low phosphate, but it's not working at all. And so your phosphate builds up and it's high as well. So that's the one difference there. Both of these, they could refer to as secondary hyperparathyroidism, but yeah, I'll refer to it more as renal osteodystrophy. The rest probably not too important. Oh, what about Paget's? Good board question. Super high, very high number ALP. Everything else relatively normal, that's your Paget's. High both of these, that's your hyperparathyroidism. Yeah, maybe you need to look at those other ones as well for rickets osteomalacia. Just talked about this, all these as well. Rheumatoid arthritis, having that rheumatoid factor and high markers of inflammation, ESR and CRP, or CCP antibodies. And in the case of the disease I had, a lot of this was similar. I had high inflammation, but I did not have the rheumatoid factor, but I had that high HLB, what was it, 27 antibody. But that's probably not common enough for you to have to remember. What disease is this? I had this on a question a couple of years ago, and it tricked some people. And I wasn't even thinking it was going to trick people. What do you think? Yeah, why hyperparathyroidism? High calcium and high PTH, those are pathognomonic for hyperparathyroidism. What's the confusing thing here? This is normal. This is a little high, but we said ALP can be high in a lot of things. It's not like up to the 1,000 level like you would expect for Paget's. Is this one confusing? This confused people. Vitamin D, what form of vitamin D is this? 125 is active. You got to have both those hydroxylations to be active. You have 1OH, 25OH, or 125OH, D. So this is that intermediate step from the kidney but after it's been hydroxylized by the liver to the kidney. And that's actually usually in serum in large amounts. I did some research into this to figure out, okay, why is it this way? That's why they measure this one. When they're measuring vitamin D, it's a lot easier, so it's a lot cheaper for them to measure this specific metabolite because it's in the serum in high amounts. Actually, the active form, even when you have sufficient, it's in serum in fairly low amounts and it's tough to test for. So why do you think this one is low in hyperparathyroidism? Think of, let's see, what is the effect of PTH being high on the kidney having to do with vitamin D metabolism? Not excretion, but this metabolic procedure, the hydroxylation, it actually activates it to create more of the active form. So your 125 could actually be high, but it's like constantly telling the kidneys to hydroxylize this specific one, which is the one they commonly test for, which actually drives that down. So that made this low in this case because of that higher PTH. So that was interesting. I didn't even pay attention to this when I put it on the test. I just thought, oh, they'll see the high PTH, high calcium, and they'll get this slam dunk, right? Because that is pathognomonic. If they did test the active vitamin D, like I said, that would probably be normal, maybe even high because it's constantly being produced. The rest of these I think were normal, yeah. All right, who's this quote by? There are unknown forces that don't want. I really like this quote. It was the end of glass. I believe if everyone sees what just a few people become when they wholly embrace their gifts, others will awaken. Belief in oneself is contagious. We give each other permission to be superheroes. Yeah, there's Mr. Glass. And I like this mark. All right, any questions on anything before we do our last Kahoot? Name a risk factor for osteoporosis. So you're gonna just type in your own here. This one's not gonna count for score. This is just a word cloud question. See what you come up with. Make sure you guys get the right one here. One specifically you need to know. I move this. We have a differing opinion here. Someone said male, some people said women or female. What do you think is correct? Old age, lack of exercise, low vitamin D. Genetics is a factor. No, brown tumor is not a risk factor for osteoporosis. Brown tumor is something that comes with what? Hyperparathyroidism. Too much clout, I guess. Yeah, calcium deficiency or vitamin D deficiency too. No, oh, we did say that. Good. Yes, most of these things are correct. All right, what is necessary for adequate amounts of the active form of vitamin D, calcitriol, in most people? All of the above. Yeah, you have to have a functioning liver, functioning kidneys, because whether you get dietary source or sunlight, it's got to go through those hydroxylations in the liver and then the kidney. So all of the above is correct. Ooh, took the lead again. What is not an action of vitamin D? Here's your different good sources of vitamin D. I'm just reading how broccoli is kind of the miracle vegetable. It has so many different things. What? Handmade broccoli? Like they mix cauliflower and And trees, my kids call it little trees. Let's see. Yeah, the yellow one was correct. It does the opposite of this, right? It inhibits it inhibits PTH production. It does promote calcium and phosphate absorption in intestines. It decreases their excretion in the kidneys, so it holds on to more. That's what we mean by decreasing the excretion in the kidneys. Results in overall increased bone density in healthy amounts. Yeah. Ooh, got a change here. Vanessa. Function of PTH, parathyroid hormone. Yeah, the big one, primary reason it exists is to ensure adequate amounts of serum calcium. The rest of these are pretty much opposite. Let's see, it doesn't necessarily ensure adequate amounts of phosphate. It's actually having the kidneys excrete more phosphate, so you may have low phosphate with hyperparathyroidism. And it promotes the formation of this in the kidneys. Good job, Vanessa, and smiley face. Just a review of that. Increases bone resorption, increases reabsorption of calcium at the expense of phosphate is how I think of it. So it just kind of makes the kidneys hyperactive, and kidneys normally are trying to hold on to as much calcium as they can, and they're expelling phosphate, promoting that hydroxylation. Step right here, or right there. And the effect of calcium is counter effect on the PTH. True or false? Paget's disease is the only one that causes elevated ALP. Yeah, it's not the only one. It's kind of the one that really makes it high and the one to remember for it for when it's super high. And most other lab values are pretty normal. Got some changes here. Who did that? Tell you what, he was one of my favorite people to work with. When he helped with radiology, he made things run smooth. What disease other than Paget's can cause elevated ALP? Just another word cloud thing. We'll see what you come up with. I'll give you way too much time. If I skip it, will that make us so we can't see the answers? I want to see the answers though. I'm worried. Don't skip. It'll probably show us the answers, right? Let's see. Yeah. Oh, I guess this one you can vote for good answers. Holy cow. Rickets. These are good answers. Multiple myeloma, yes. Those are all grouped together. Hyperparathyroidism, osteomalacia, yes. Yeah, I believe all of these are correct. I don't know about that one. Maybe if there's enough bone resorption with a quickly growing OKC, but I don't know about that does it. I don't know about osteopetrosis. Someone's done. Tell me who this is so I can give him an automatic fail. Just kidding. All right, Ryan, you're done. Oh, you can vote on them. Let's just give a few seconds for this. Just vote for your favorites. We'll just see what rises to the top. See, you're wearing a Duke shirt and not a Ute shirt. All right, just another few seconds just for fun. I actually had to use a different login. I used Dr. Freita's login because she has a version of Kahoot that let me use this type of test question. I've never used this one before. It's actually going through the reveal thing. Hyperparathyroidism, good. It's an Osteomalacia. Dane's hair. Okay, same one. Yeah. That one definitely can. So that's a good one to think of. Oh, I guess that affects your scores. I didn't even know that. So that helped loops and Dane's hair jump to the top. So yeah, we said hyperparathyroidism, rickets or osteomalacia, myeloma, metastases, fracture healing, all those can do it. All right, you're going to look at lab values. You're really familiar. Yeah, okay. Remember that one since we went through that at the end. Loops in the lead. Oh, I thought well, we already talked through that one, so we're all good. Term for hyperparathyroidism causing generalized radiolucency and multiple tumors is osteitis blank blank. Crossed it out here so you can't see it. You got to type it in. Starts with 5. Ooh. Oh, some people just mistyped it. Hey, someone said, I don't know. You got credit for that. Beats me would have got credit too. No one chose that one. Fibrosa, not fibrous. That was close. Yeah, brown tumors are the type of tumors that it has. Someone wanted to type out the whole osteitis, but I just wanted you to do those blanks. I was limited with how much space you could do this question with. There we go. Ooh, that helped out Jungle Diff. Are you the one that said, I don't know? In secondary hyperparathyroidism caused by renal osteodystrophy, you may see elevated calcium and phosphate, or PTH, not phosphate, parathyroid hormone levels. True or false? Secondary hyperparathyroidism, does that cause high both? The answer is false. So yeah, primary hyperparathyroidism is the only one. With renal disease, renal osteodystrophy, you've got lower calcium. That's what's causing higher parathyroid hormone. Yeah, you need that healthy kidney to have adequate amounts of vitamin D. Without adequate vitamin D, you have lower calcium. Ooh, that helps out Real Teddy. I think there's 2 more. Okay, this is just phosphate levels in renal osteodystrophy. What do we say about that? So the kidneys are not working. The kidney's not working. What's phosphate levels going to do? Just to go through the whole thing here, renal osteodystrophy, because of that lack of the active vitamin D, you're lowering calcium, which then elevates PTH, increases bone resorption to try to maintain normal calcium levels. Most of you did get it, yeah. This was the big one with with kidneys not functioning. Kidneys are trying to excrete phosphate. If you have a lot of bone turnover, a lot of bone resorption, and your kidney's not excreting the phosphate, it's going to go high. What was the media? Yeah. One more, I think. Actually, real teddy. All right, dietary and supplemental vitamin D is cholecalciferol, vitamin D3. That was before the hydroxylations. So when would someone take calcitriol, 125 OH2D? I don't know how long that medication's been around. Yeah, kidney disease, because they may have adequate amounts of vitamin D. Maybe even the what was the first one? The one from the liver was the 25 OH vitamin D. But their kidney's not hydroxylating that last step, so they have low of the actually active form. This would be a case where they might actually test for this in the blood, even though it's harder, it's more expensive than the typical vitamin D test. And so, yeah, they need this active form, the calcitriol, for kidney disease. I so miss doing the awards thing. I don't know why it does this for me. But actually, real Teddy, go ahead and take a bow. Who won our last one? They didn't admit to it, whoever it was. Jungle Diff and Dane's hair was close. All right, do you guys have questions for me?